So our last talk is a little bit of a different one in that we don't have a straight kind of topical progression from history onward, although we will be moving in a roughly chronological way. But before, with the other talks, I was able to talk about major themes and how concepts changed. And this lecture, is largely going to be about a list of people who were the first to break into mainstream medical research, medical practice, and what the impediments were. So it's a little bit more of just a list of names, and it's a little bit decontextualized, but it's because the people in today's talk were largely excluded from the major historical developments in medical science that we've talked about this whole time. Now, a couple caveats before we begin. This presentation was actually the brainchild of Christine Carroll, class of 2015, so Dr. Christine Carroll, and wanted to really kind of address the people who were not, basically the people who don't look just like me, white males, we've had it pretty good, let's face it. So this lecture is really about not just trying to recognize those who broke through the barriers, but also look a little bit at what things held them back and how we can anticipate issues like that in the future and kind of remedy it a bit. One thing before I begin, one other caveat, is I'm not going to be able to touch on every single topic. There are more excluded groups out there than you could really summarize in 1 hour at your best. And you'll notice I've really held pretty much onto Western medicine as a theme for this course because it's what really led to the practice that you guys have. Osteopathic medicine is, by and large, part of the Western tradition of medicine. That's nothing against Eastern medicine, Ayurvedic medicine, things like that. I just don't know enough about it to speak intelligently on it. Maybe that won't be the case someday, but it's not something I have a great deal of insight into, hence it's being deliberately excluded, but not out of malice, simply out of my inability to bring that and put it in the context of your own practice. So let's talk first about the presence of women in medicine, because women, historically and today, make up 50% of the population, or slightly more. So the first evidence we have for women in a healing context comes from Egypt. There were goddesses of healing, like Isis, and not surprisingly, they were associated with women's diseases, childbirth, and making sure that women were able to get through that process. There's no real evidence of midwifery at that time, but it's felt that the priestesses and the followers of Isis were involved in women's healing and also helping people through the process of giving birth and thereafter. Asclepius, the Greek god of healing, who may have been based on a real person, had several daughters, and they were not necessarily actual historical people, but they were representative of concepts like a lot of the other Greek gods were. And in this case, the two biggies were Hygeia and Panacea. And these two women, deities, were there to kind of show the interventional side, Panacea, of medicine, and the preventative, Hygeia, side of medicine, and basically public health. The first named woman we know of historically is an Egyptian physician, and her name was Ptah. I don't speak Egyptian, so if I'm really screwing that up, somebody let me know. And that's going back to about 2500 BC or BCE. And essentially, she is on record as having trained as a physician and surgeon. Keep in mind, surgery at the time didn't necessarily mean massively opening up the body and doing things with the organs, but dealing with wounds and dealing with maybe suturing or cauterizing wounds that were bleeding freely. She was called the chief of the physicians and therefore had pretty good prominence at the time. She trained and was able to give not just medical advice to women, but also to others. But she was very much involved in the treating of and training of female physicians, describing female anatomy, surgical interventions, OBGYN, what we'd consider to be OBGYN now, and was roughly contemporary with Imhotep, one of the figures in Egyptian medicine who was also linked to healing in general. Now, there's a big blank period there because Egyptian civilization was relatively, for the time, was relatively egalitarian for men and women. And I mean at the time, meaning it wasn't even remotely equal, but much more so than what came after. Greek civilization, classical Greece was what we'd call institutionally sexist to a remarkable degree. Women were almost never seen out of the home, and if they were generally veiled. There were very few public events that women were able to attend, and they were kept in kind of the constant oversight of a male relative or husband. So a woman doctor in Greece was something that was absolutely unthinkable. The only one we know of was, I'm going to mess this up because Greek is not something I'm relatively fluent in, Agnodice, and that's going to be about 300 BC. She was a woman physician who passed herself off as a man in order to study medicine, studied with Herophilus, and that's in Alexandria. Herophilus was one of those early anatomists who conducted human dissection in the city of Alexandria, and she practiced after studying secretly until she was denounced by a fellow doctor who, out of professional jealousy, decided to report her as a woman practicing as a physician. She was sentenced to death, but amazingly, particularly amazingly for Greek society, she was saved by the revolt of multiple women patients who really did not want her to be put to death because they knew they would get good medical treatment from her. And it didn't hurt that a lot of these women were the wives of influential Greeks in Alexandria and Athens. So she was able to be saved only because she was really catering to the upper class women in Greek society. So in the classical era, there were major roadblocks and barriers to women, not just the ignorance of medical science in general, but the cultures of ancient Greece and Rome were just completely suppressive to women. Women had very, very little that they were allowed to do in the public sphere in terms of getting an education. So the fact that there were very few women physicians is pretty much reflective of the very little kind of routes for opportunity that women enjoyed at the time. Interestingly, though, there were multiple goddesses involved in healing in both the Greek and Roman pantheon. So there were goddesses associated with healing that people could pray to. Asclepius was obviously the big name in Greece, but he had the two daughters, Hygeia and Panacea. And as the classical civilizations gave way to the monotheistic religions that came in during the medieval era, Christianity and Islam, taking up a great deal of the geography of the Middle East and that Mediterranean area, not only were there going to be no women goddesses, there were not going to be multiple gods of any kind allowed in the pantheon. So even the representation of women goddesses were going to be gone without really opening up any new avenues for women to practice medicine. Interestingly, though, there were always going to be some women operating as midwives, nurses, and so forth, whether they were domestic slaves of upper-class Greek and Roman women, or whether they worked that way professionally. Often women who were widowed and wouldn't have any other means of support would become midwives, and they were present throughout this entire period, but there's very little record of them in the writings of ancient Greece and Rome because they were not considered to be someone you would really take note of. They were lower class, and in general, the Greeks and Romans didn't waste any ink on someone who wasn't a great person, and at that time meant being a great man. So, moving into the medieval era, we've got a few big names. Things, I can't say they got better, but the culture was less controlled. There was less central control. Roles for women opened up a little bit only because there were fewer people checking on the population and enforcing uniformity across the entire European and Middle Eastern landscape. Hildegard of Bingen is one of the first names we have in the medieval era, and she wrote on a lot of topics in medicine. She is a nun. She described medicinal plants in her book Physica. She had another book called Causae et Curae, working on 50 different diseases and how you could actually go about treating them. Keep in mind, she was still hamstrung by the medicine of her time. The humoral theory, other things that were not particularly effective were still the norm. So even though she was working as a bit of a bright spot at this time, it didn't mean that her methods or her understanding was going to be any clearer than her male counterparts. But she did note certain things that others either hadn't noted or had, such as diabetes and blood sugar, circulation and how it worked. She didn't quite describe circulation, but noted pulse activity and the movement of blood. And thought that disruption of the bodily humors would cause disease, but also that it could be passed from person to person. Kind of a loose idea of contagion taking shape in that pre-Black Plague era. She worked a lot in women's health, talking about the female reproductive system, childbirth, and so forth. And this is a picture we have of her. And anybody else? I think she looks a lot like Maggie Smith. And if Maggie Smith is immortal, that would make me very happy. All right, so in the medieval era, what was the role of women in healing? What was the role of women in general? And what kind of kept them from equity from their male counterparts? Well, essentially, women healers had to operate kind of on the down low. They had to be not seen as any kind of a competition to the physicians and surgeons and barbers who were working at the time. So wise women or old women would sometimes be considered people you would go to ask medical advice from. They might prescribe some herbs. There's a big problem, though. If you are a single woman who has some sort of property, you're able to prescribe herbs, what can you be accused of pretty easily? She's a witch, exactly. So witchcraft was nothing to laugh at the time. People got put to death very regularly, especially if some treatment didn't work and you were a little bit bitter about your child dying. You might accuse the physician rather than the person, the fact that it was a death that might not have been preventable regardless. So many, many women, it's estimated that between 50 and 100,000 were killed over that era. I actually have to hunt down that source because that sounds a little bit iffy, and I'd like to find out exactly what span they're looking at. But suffice to say, being accused of witchcraft was a very real threat to any woman working in what we'd call healthcare at the time. In Paris, there's a woman named Jacoba Felix who was accused of practicing medicine and doing horrible things like visiting the sick, examining their urine, feeling the pulse, touching the bodies and limbs of the ill. And the fact that she was caught doing this was what was a big problem. Midwifery was something that people could allow because male doctors and physicians were not necessarily allowed to inspect women when they were in the process of giving birth. But to actually be seen as a competitor to male counterparts was absolutely and utterly shut down. And the medical authorities of the time, in the mid-1300s, had pretty much locked out women in general. And the only reason men had not taken over midwifery is because they hadn't really thought of it yet. And that had to wait until much later when midwives were more or less pushed out of the mainstream in the 1900s. So the lower class, women patients, you could probably be okay working on them. But are those people going to take notes, record your name for posterity? Not at all. So we have very little in the way of who these practitioners were, what their methods were, and the fact that their methods were probably no better than their male counterparts means that they didn't have such spectacular results that there would have been notes taken about it. One interesting thing we have documentary evidence of is that Queen Elizabeth I was petitioned by one of her inner circle to overrule the College of Physicians who had pretty much put on trial a woman who was accused of operating as a healer. And it's kind of, I won't read the whole thing, but her Secretary of State, Frances Walsingham, pretty much put the case forward on this woman's behalf. Her name was Margaret Kennicks, and her husband was disabled, and she had to find some way to work and make a living, and she was actually quite a good healer. I think in the middle there we have, let's see, that she was a pretty well-pronounced healer. This poor woman should be permitted by you to quietly practice and minister to curing of diseases and wounds by means of certain simples or simple treatments, non-compound things, in appealing whereof it seems God has given her a special knowledge to the benefit of the poor sort. So he's basically just asking, please let this woman have her meager practice. And the College of Physicians replied to the Queen that thank you, but we're not going to allow her to practice because it sets a horrible precedent that women might actually be able to practice medicine. So even in her case, with very good results, this was absolutely shut down to the point that the College of Physicians actually contradicted the state and the Queen of England in her treatment. So moving from the medieval and early Renaissance into the more modern era, There were lots of different healers around, of both men and women. Healers and medical practitioners of various types fit in certain categories. There were apothecaries, and they prepared and sold the medicine, so basically like pharmacy today. Midwives, who helped with childbirth and were mostly, almost all women. Bone setters, these people would take non-compound fractures and try to set them, lash them together with some sticks, try to help the bones to heal up and knit. And surgeons, who we've talked a lot about. They did a lot of bloodletting, worked on some amputations, but not too much of an invasive practice because people just were not going to survive that. And lastly, but not least, physicians who did what we would call internal medicine. They prescribed, tried to diagnose what people were doing and give some sort of a humoral approach treatment to help them get better. So these people were pretty much the healers at the time. And what's interesting is they all treated the patients differently, but they all agreed on the same underlying principle and paradigm of what health actually is, an imbalance of the bodily humors. Now just take a second, and despite all the talk of progress that we've made, think about the various types of healers that are out there today. Obviously, we got DOs, MDs, nurses. What else? Counselors? Therapists? What's that? PAs? PharmDs? They all basically agree on the same underlying principle of human health and human structure and how it affects. So it's interesting that we've got a really similar setup. We just happen to have a completely different concept of how health and disease operate. So the four humors were knocked out of medical practice relatively recently. It wasn't until about the 17 to 1800s that doubt and outright dismissal of humoral theory happened, and it really didn't permeate culture until much later. It's said that Stonewall Jackson, before the Civil War battles he would go into, would lift his arms over his head and kind of wiggle his fingers to get his humors moving a little bit better. So it's still out there. But this took about 1,300 years to dismiss, and we spent a lot of time talking about the humoral theory and how understanding of anatomy, pharmacology, and pathology eventually got rid of that concept. But what if there was something else that was even more pervasive and had stuck around even longer than humoral theory? You have no idea how long it took me to actually make this stupid little meme. It's like a monkey trying to operate an airplane. Okay. So there was another medical error, which turns out to have been a massive bucket diagnosis that was around for over 2,000, more likely 4,000 years. And it is hysteria. I heard this described recently, and I love the definition. Hysteria, aka being a woman disease. So hysteria was something that women could be diagnosed with for any number of reasons. And what's it called when you take out someone's uterus? Hysterectomy. It's because the ancient Greeks thought that the reason women went crazy at menopause, for everybody in the other room, I did the air quotation marks when I said crazy, is that their uterus detached from where it was normally located in the pelvis and wandered around their body, upsetting the humors and creating all kinds of chaos. And to remove the crazy was to do a hysterectomy and get the uterus out. Now, eventually, it was discovered, okay, the uterus doesn't really wander around, but somehow it's responsible for how women act, and especially how women act in ways that are inconvenient for the men around them. So this belief in the uterine source of hysteria took a long, long time, even after people understood what anatomy was, for it to eventually disappear. And from the Middle Ages up until very recently, hysteria was believed to be due to anything you wanted to think about. It could be because of too much abstinence, or too much sex, or thinking about too much sex. Anything that you could label as even slightly away from the norm was likely to lead to a diagnosis of hysteria if the particular woman in question happened to be making trouble for or inconvenient to other people around her at the time. So in the 1800s, it was considered to be neurotic in origin. It was treated with psychoanalysis. And it was finally recognized as a complete, just garbage. It's not a diagnosis that actually correlates to anything real, and was finally excluded as a diagnosis in the DSM-3 way back in 1980. I was alive when this was a thing. That kind of blows my mind. Anybody here alive when humoral theory was around? Okay, no, so okay. No immortals wandering around, that's probably good. All right, so eventually, things like hysteria got knocked out of the medical lexicon, but this took a long time. And medicine, like society in general, is really good at ignoring the things it's bad at and using what it has to justify the status quo. Now, granted, the status quo is not always bad overall, but there's always bad things that are supported by the status quo in any society. So, as medicine changed, it had a vested interest in keeping medicine relatively uniform. And so medical science took a long time to dismiss things like hysteria and instead spent a lot of time justifying things like hysteria. So in the 17th century, when the humoral theory was still holding fairly good sway, it was believed that women's brains were too cold and soft for the strenuous work that was required for medical practice. So the science of the time was used to justify the existing status quo. We move along into the 18th century, and women just didn't have big enough skulls to accommodate the work that needed to happen. We just didn't have big enough brains compared to their male counterparts. That was one of the justifications brought on by phrenology. Now, we didn't talk about phrenology in this course. It's something we could work in a little bit when we talk about neuroscience and things like that. But what's phrenology? It's basically the idea that was relatively popular in the 1800s, that you could tell someone's character and capability based on the bumps and the size and the shape of their skull. So you could palpate and say, oh, this person has great creative activity because this side is a little bit more expanded. This person's obviously a criminal because they've got a very small frontal development, things like that. It's bunk. But it was very popular at the time, and as something that was popular, it was used to justify exclusion of women, because women, in general, have smaller heads and therefore smaller brains than men. Now, these days, we know it's not the size of a brain, although a certain minimal size probably helps, but it's the connections and the number of neurons that are present that correlate more with capacity. If you think about dogs, I don't like small dogs, I'm not a huge fan, but is a Chihuahua that much stupider than a Great Dane? So it's not the size of the brain that really matters. Okay. Bad metaphor. We'll work on that. But basically, the justification that was convenient was the one that enjoyed popularity. And then in the 19th century, when medical science made great strides chemically and physiologically, it was felt that too much exercise, aka thinking, would actually shrivel a woman's ovaries and make her unable to procreate. And that was used as a reason to keep women away, not just from medicine, but any sort of scientific activity. So just real quick, I'd like to poll the audience. Has anyone heard any interesting genetic justifications for why women should not be involved in medicine? Or any contemporary science being used to justify excluding women from stuff? Yeah. Yeah, okay, good. So for everyone in the other classroom, in Japan, and it's not just Japan, but they got caught recently, University of Tokyo Medical School had been excluding women because it was felt women were going to be more likely to have babies and therefore not work as much as their male counterparts. And that, they got in trouble justifiably for that. That's actually a major problem a lot of places. And just for your information, ladies, women, if you get asked anything about your desire to start a family, how many kids you want in an interview, you're not supposed to be asked those questions. So start strategizing on how you can kind of covertly say, yeah, I don't really want to feel like answering that right now, because they're basically trying to see if they can work you to death and not have to actually make a big deal out of it at the interview. Any others? Yeah, the good news is, as a little bit more equity has happened in society, we get fewer and fewer of those scientific, quote-unquote scientific rationales for excluding people from medical practice. All right, so women were pretty much barred from practicing medicine until the 19th century because they couldn't go to medical school if they couldn't go to college, and they couldn't go to college if they didn't go to high school or its equivalent. So even when women could obtain a medical degree, they frequently couldn't obtain the degrees that would allow them to attend medical school. So nice little catch-22 present right there. Hospitals would even then not allow women who had medical degrees to practice. So it was incredibly difficult, even when there were officially no barriers, for women to actually gain a foothold and practice effectively. A lot of times they practiced with husbands or other male partners or family members if there was already a foothold and a little bit of a friendly relationship present a priori. So this is a little bit of a preview, but I do want to mention it's a justifiable thing to take some pride in osteopathy for being a lot more egalitarian than other things at the time. In 1892, when the first School of Osteopathic Medicine opened, women were allowed to matriculate on an equal basis as men. A year later, Johns Hopkins opened, ostensibly with a similar equality in their admissions. Harvard and Yale, the big names, it wasn't until after World War II women were even allowed to attend. Yeah. So let's talk about a few big names for more contemporary times. Elizabeth Blackwell graduated from the Geneva Medical School. That's actually in New York, not in Geneva, Switzerland, but she graduated in the mid-1800s and founded the New York Infirmary for Indigent Women shortly thereafter. Founding medical hospitals, medical practices was one of the only ways women could practice because they had to take matters in their own hands because other institutions might not allow them in even if they had the qualifications to do so. Worked to take in patients after the Civil War was underway and getting the nurses prepped to actually handle the massive number of casualties and injuries that came through, and opened up the Women's Medical College with her sister. And as you'd expect, to maintain a college, you have to maintain standards. You have to set a fairly decent curriculum. You have to have pretty good examinations and standards to make sure that your patients see your graduates as being capable of doing the work. So she did that. In England, Elizabeth Garrett was the first woman to graduate from a medical school, and graduated not from a medical school in England, however. She had to go to Paris in order to do that, and later opened up a dispensary, or what we'd call kind of a pharmacy with an attached practice in England. She was able to found the London College, or School of Medicine for Women in 1874, and just like Elizabeth Blackwell, had to then make sure that the standards are maintained so that their graduates could not be dismissed easily for lack of rigor. Maria Montessori in Italy went to the University of Rome, and you are probably familiar with her more for Montessori schools rather than her actual being a physician. But she was a physician, but worked in a psychiatric clinic and realized that the people with developmental delays were capable of a lot more than was being asked of them. And the educational program that she put together to help these people reach their potential had a lot more potential than just working with the developmentally disabled. It was something that could benefit many, many people, particularly young children, in helping them explore and gain capacity in a not quite as regimented scholastic environment. So just remember, whenever you see Montessori schools, she was actually an early woman physician who was able to bring that knowledge into a little bit broader context. Now, Maude Abbott came up very briefly before because she's a Canadian physician, graduated from McGill, tried to get into medical school there but was denied entry. So she had to do what others had done. They had to go to Europe, where the high caliber medical training was present at the time. So she went to Europe, went to Zurich, and graduated from the University of Vienna in 1898, and came back to McGill. What's interesting is they wouldn't let her into medical school, but she came back and became a professor there and had a massive collection of cardiac abnormalities, pediatric heart defects, and she put together a massive atlas of these different defects. And she was consulted by Helen Taussig, the woman who worked and was instrumental in getting the first heart operation to occur. So Helen Taussig, as we mentioned earlier in the surgery talk, graduated from Johns Hopkins and was encouraged to go into public health refused. She wanted to be a physician, and after getting out of Hopkins was advised to go into pediatric cardiology. Now, it's a bit of a misnomer because pediatric cardiology wasn't really a thing at the time, but she worked on a cardiac ward that was exclusively for children, and it was mostly about keeping them comfortable until they inevitably passed away, because there was nothing you could do for any heart problem at the time. Along with Dr. Alfred Blalock and Vivien Thomas, she came up with the idea to create an artificial ductus arteriosus to help patients with tetralogy of Fallot get some mixing of the blood rather than complete cyanosis resulting from the defect that they had. So she was able to pioneer this surgery with the other two and published a textbook, came out in 2 volumes, and a second edition after not too long, on congenital malformations of the heart. And that was a major impact, but later she did something even, well, not even more amazing, but also really interesting, is that thalidomide is a drug that was marketed as an anti-nausea medication in Europe. Problem was thalidomide is really, really teratogenic, meaning it creates mutations, specifically mutations of limb development. And there were a lot of children being born with what was called phocomelia, where they had shortened limbs, they were missing limb segments. And knowing this, kind of figuring that out, she was able to campaign along with Francis Kelly, the head of, I think, the USDA at the time, to stop thalidomide from being marketed and sold in the US, which is why the United States had far fewer cases of thalidomide-based phocomelia than anywhere else. So she did have that engagement throughout her whole career. Now, jumping back just a little bit, as I mentioned before, women in osteopathic medicine were accepted on a relatively equal basis, and there was quite a bit more equality in osteopathy for women. We can't say it was ever perfect, but it was quite a bit of an improvement compared to the MD situation at the time. So in 1894, there were 4 women in the first graduating class: Nettie Bolles, Lou Kern, Mamie Harter, and Blanche Still. The name Still comes up a lot. You'll see that again. The AMA, not that I'm anti-AMA, but just for reference, the AMA did not accept women as members until 1915. And the AOA had women accepted on an equal basis as men from its inception before 1900, in 1897. So in 1908, about 35% of the DOs in the country were women, and by 1923, 50%. So rough equity had been achieved by the 1920s. And let's see, but it took until 2009 for Karen Nichols to become the first woman president of the AOA. So can we say it was perfectly equal? No, but it was an improvement at the time, room for continued growth. So a few of the prominent women in osteopathic medicine: Nettie Bolles was raised in the osteopathic tradition. She was very involved with it from the early days of the Kirksville School. She was the first editor and publisher of the Journal of Osteopathy, now the JAOA. And she became the first vice president of the AOA and was the first woman to be nominated for president of the AOA, although, as we noted, it took 90 more years for a woman to actually be elected president of the AOA. Louisa Burns really pioneered a lot of the viscerosomatic research that's taught in the osteopathic tradition and how manipulation relates to changes in the different organs. So looking at how manipulation of the skeleton and musculoskeletal elements of the body can actually affect heart rate, peristalsis, things like that. So I have that arrow in this really busy table to show the high watermark in recent times. If you look at that arrow, that's showing that of a total of 16,168 medical graduates in 2007-8, 49.3% were women. So perfectly equal? No, but we've gotten a fair degree of equity. If we go by the pure population, equity would be around 50.1%. So not quite there, but obviously better than historically. Moving on to underrepresented groups in the United States, we have African Americans in medicine. And, big surprise, a lot of the same arguments that were put forward for excluding women from medicine were put forward from excluding racial minorities and African Americans, black people in general, from practicing medicine. So in 100, there were actually 10 medical schools in the US that accepted African Americans. But in 1910, along comes the Flexner Report. Now, what did the Flexner Report do? It set the standard. Good answer. It set the standard for medical education in the United States. That standard was improved in terms of academic rigor, clinical experience, and scientific education. But it also was very, very favorable to the existing MD schools, particularly the Hopkins model. I think I mentioned already Simon Flexner, who was pretty much the sole author of the report, was the brother of one of the professors at Johns Hopkins. So kind of an interesting conflict of interest there. Many schools closed, particularly osteopathic, and schools that were going to accept minority students were affected because they didn't have the money to necessarily meet all the criteria that were being asked of them after the Flexner Report. So by 1923, there were actually only 2 schools left, Meharry Medical College and Howard University, accepting black or African American students for training. 2 schools. So the Flexner Report, big surprise, didn't see this as a problem. And it says, well, maybe African Americans should just focus more on public health and other affiliated fields and leave being a physician to the white people. So gives you a good sense of what was going on back in the 20s and so forth. In 1948, after desegregation began more or less in earnest, attendance at medical schools became a little bit more of an option for African Americans. And 2 new, primarily African American schools opened, Charles Drew University of Medicine and Morehouse School of Medicine. I was kind of bummed out. I went to a meeting at Morehouse this last year, and I was hoping to look around, but the meeting was hosted by Morehouse, but it was actually held way far away from Morehouse, so I didn't get to actually tour it at all. So a few prominent names. James McCune Smith, in 1837, graduated from University of Glasgow in Scotland. Scotland would accept him as a medical student. No place else in the US was going to give him a shot. So he did what many other people had to do. He went to Europe, where the standards were a lot less prejudiced at the time. So he began practicing in Manhattan, became the first African-American physician officially in the US, and ran a pharmacy as well. Very interestingly, he was really well known as a doctor in his community, but was also really well known as an abolitionist, writer. He was really closely involved in working with Frederick Douglass in the abolition movement, and really got the Underground Railroad in New York operating to help runaway slaves get to a place where they could actually survive up in the northern states just before and during the Civil War. So really amazing person, really amazing story, but we only really recently got a sense of how interesting he was as a person, because he was excluded from the AMA as well as other local medical societies because obviously he was black. And really amazingly, his relatives didn't really want to draw attention to him. They were more put off at having an African American, a black relative, than they were proud of his accomplishments as a physician. And that's just a really messed up situation where you find that this person's race is more psychologically off-putting to you than the fact that he did so many amazing things. So his relatives didn't even always know that they were related to him because he had largely been erased from the historical record at the time. So only just now are we getting a little bit more of a sense of all the stuff that he did. First African-American woman that we know of to earn a medical degree was Rebecca Lee Crumpler, coming from New England and graduated from the New England Female Medical College in 1864. So she did a lot of work in her local community, and when the Civil War ended, she actually moved to Richmond, Virginia. Think for a second about how gutsy that has to be. You're a black woman moving to Richmond, Virginia at the end of the Civil War. And she was there to treat the newly freed black citizens in the South, people who were used to very little in the way of consideration, medical treatment, and so forth. And she really persevered against some really, I would imagine, unbelievably confrontational and antagonistic community around her at the time. So she eventually continued to practice and took a very keen interest in women and children's health thereafter towards the later part of her career. Another name, in Chicago, we have Daniel Hale Williams, and he was the son of a barber, so had a medical kind of upbringing already, attended the Chicago Medical College, and graduated in 1883, so just after the Civil War, about 15, 20 years thereafter. And in Chicago, he founded the Provident Hospital. It was the first black-owned and non-segregated hospital in America. That's in Chicago. And very amazingly, so in 1893, a man arrived at the hospital, in the Provident Hospital, with a chest wound. And he actually did a thoracic procedure. This guy had a wound to his pericardium, and when the guy went into shock and was about to die, Daniel Hale Williams decided that he was going to operate and actually stitched up some of the pericardium. So was it truly a heart procedure? Depends how you define it. It was a pericardial procedure, and it did actually save the person's life. This was maybe the first thoracic or heart operation on record working around the heart. So there were some other people who did similar things. There's a guy named Henry Dalton in St. Louis who did a similar operation at a pericardial wound. Didn't operate on the heart itself, but that account didn't come to light until later. So pericardium worked out there. Oh, and I should mention he taught clinical surgery at Meharry and co-founded the National Medical Association, a competing medical association with the AMA, which was not going to be anywhere near as welcoming to black physicians at the time. I brought him up just before Vivien Thomas because Vivien Thomas is considered to be one of the people most involved in the first real heart operation. But how do you define it? It wasn't an operation on the heart itself, it was an operation on the large vessels around it. So whether you draw the line at the heart itself, the pericardium, or the large vessels, kind of determines where you kind of put the tracker down for the first heart operation. But Vivien Thomas grew up in the South and wanted to be a physician, but his savings were wiped out when his bank failed, and he was left basically just to keep working. And he started working at Vanderbilt, first as a janitor, but Dr. Blaylock, Alfred Blaylock, who was a surgeon at Vanderbilt, had him in his lab and noticed that he was incredibly skilled with his hands and started putting him to work as a lab assistant. And lo and behold, Vivien Thomas didn't just have good hands, he had an excellent mind. And he was really able to start some really pioneering work in terms of operative surgery, looking at how shock happened, and coming up with different animal models for how disease processes developed and how you could actually do operations to fix it. So when Dr. Blaylock moved to Johns Hopkins in Baltimore, he talked Vivien Thomas into coming with him. Now, interestingly, Baltimore was very much kind of a hostile environment for black people at the time. Vanderbilt was actually really a shining example of a fairly enlightened area compared to Baltimore. So he was going to a relatively hostile environment, but the work they were doing was so important, he felt it was important to go along with Dr. Blaylock and keep this work going. So after they had been contacted by Helen Taussig, they started looking at ways to do operations to relieve tetralogy of Fallot. And Eileen Saxon, the 11-month-old girl who was the first person to have this procedure done, took a turn for the worse, and they had to operate relatively quickly. And I mentioned this in the surgery talk, but it's still a relatively amazing moment, is that Dr. Blaylock, the chief of surgery at Johns Hopkins University, had to do this operation on short notice, and he'd only ever done it once before on a dog. So the operation got started, and just before they made the incision, Dr. Blaylock bailed. He said, "I'm not doing this. We need to get Vivien in here right now, get him scrubbed in." And Vivien Thomas, his black laboratory assistant, assisted the white chief of surgery at Johns Hopkins University, standing over his shoulder, standing on a stool, directing him in how to perform the procedure. And the procedure worked. Now I'm going to put a little bit of an asterisk after that. It worked, and Eileen Saxon lived for another 2 years. But subsequent patients, particularly older and larger children, had even better results. 685 of these patients survived over 2 months, and 441 out of 685 survived more than 15 years. And at that point, the heart-lung bypass machine had come along, and we could do a direct repair rather than just changing the plumbing around. So Vivien Thomas did not receive the same level of awareness for his contribution to this as Dr. Blaylock and Helen Taussig. He was relatively excluded from the publicity that came along with it. But after a while, his contributions were recognized. He was given an honorary MD from Johns Hopkins, and his portrait hangs next to Dr. Blaylock's in the Rotunda area at Johns Hopkins. So once again, there's an HBO movie based on this called Something the Lord Made. It's a good thing to watch over your Christmas break, holiday break, as you get a chance. All right, so where are we now? Or more correctly, where were we a year ago when I pulled these tables from the internet? So if we're looking at medical school applicants, so applicants in red, matriculants in gray, and graduates in blue, we can see that underrepresented minorities, we have relatively few compared to the vast population of medical school applicants, matriculants, and graduates. So a lot of work to go into this. There's nowhere near the level of representation of underrepresented minorities, hence the name, than there are of women, who are almost, as a group, at 50% or a little bit more. So a lot of work yet remains to be done. Physician workforce by race and ethnicity 2013 is going to be similar. We have a very steep step off going from Caucasian or white physicians down. Next we have Asian physicians, and then Hispanic, Latino, Black or African American physicians, and then other underrepresented groups, very minimal representation. Obviously the pool gets smaller as you go, but still quite a bit of work to be done until there's pure and total equity with the population at large and medical school applicants, matriculants, and graduates. So in osteopathic medicine, here are the numbers. We're looking at, as a whole, underrepresented minorities just under 9 to 10% in general, and female medical students just under about 45%. So those are the numbers. Obviously, we can congratulate ourselves on the strides that have been made, but never be complacent. And particularly, you want to not lose the lessons of history. And that's where I want to finish up this series of talks. There's a lot of different things that have happened throughout medical history, and they don't just relate to underrepresented groups, but they relate to how people are willing to fool themselves, how people are willing to ignore evidence or not even bother to collect evidence in the first place. One thing that's really interesting is a lot of it comes down to how well you promote the good work you're doing. A lot of the things that we've seen as monumental discoveries were not actually technically the first people to discover those things. So go way back to Hippocrates on the island of Kos, the guy who gave us humoral theory in the first place. Was he a bad physician? No, he was good for his time. He taught students to take good, accurate observations, to have a good professional identity, to be trustworthy, but his theory didn't hold water and was accepted for a long time because people didn't bother to look. One amazing thing is that not too far away, there's another island. Anyone here Greek or know how to speak Greek? Okay, I'm gonna murder the name of this island then. Agnodice. There's an island nearby called Agnodice that conceptualized illness as due to diseases and afflictions of the organs inside the body. Much more in line with what we consider to be accurate today. Why didn't it take precedence? It was because it didn't have all the other stuff that Hippocrates brought to the table, a professional identity, that skill in observation, and even if people have a problem with their organs in ancient Greece, what are you going to do about it? It didn't give you any additional therapeutic advantage. So we've mentioned already, William Harvey, discoverer of the circulation, did not discover circulation first. So we had people in the Islamic and even in China, there were also descriptions of Islamic empires as well as in ancient China, there were descriptions of circulation and that the blood made a circuit around the body. Didn't necessarily go into pulmonary versus systemic, but Harvey was not the first, but he was the first to make a big impact. So Hua Tuo, a Chinese physician in the 1st century, is reputed to have used anesthesia. We don't know what method, but using something to knock out patients so that you could actually procedure. Imagine if we'd had surgical anesthesia from the 1st century onwards. We didn't get surgical anesthesia until the 1850s. And decades before Joseph Lister came up with the application of germ theory to surgery, and before Ignaz Semmelweis said that we should wash our hands before examining patients, we had British physicians as well as a relatively well-known American essayist, a physician and anatomist called Oliver Wendell Holmes. He was the father of the Supreme Court Justice, Oliver Wendell Holmes. Basically said, hey, maybe people are spreading disease from patient to patient with dirty hands. Think of the lives these people could have saved if they'd been able to force that out a little bit further. And for that instance, think of how much better things could have been if Ignaz Semmelweis had pushed his reforms through and not given up and had poor communication keep people from being saved from infectious disease for that long. So what's the difference in successful versus unsuccessful communication? It's really tough to say, but one quote I've really come to appreciate is that great ideas and great inventions do not necessarily win acceptance because of their inherent value. And that applies not just to medical inventions and discoveries, but also to people. You don't necessarily see the value in the other people around you. You have to be willing to push and get the word out about what people have to contribute, and hopefully get to a point where medical science truly investigates things based on the data, based on a relatively unbiased appraisal of efficacy, as well as really looking for and nurturing the talent of everybody out there, regardless of their socioeconomic status and where they're coming from. You really let that talent speak towards the development of medicine moving forward. All right. I have no idea how to end this properly, so that's all. And thank you all very much for coming. So a little bit of word on where you go from here. So there will be the sign-up sheet. Make sure you've gotten a hold of that if you haven't already. The survey will come out. Make sure you fill out the survey. And I'd like to thank NAUPA in particular for hosting this session. So get the survey filled out. And if anyone missed one of these sessions, the videos will be uploaded on the WSOM educational channel. If you missed one and you want to do a quick little essay on what was covered, that's one way you get credit for having that session. Those of you who want to get the, we're going to call the Distinguished Scholar of Medical History certificate, here's your job, and we'll send out an email. I want you to write a relatively short, but substantial, something around in the vicinity of 5 pages, give or take, let the topic speak to it, on one of the people, one of the developments, one of the themes that's come through in medical history, and how you think it's going to relate to you as a practicing physician. How can this person, this process, or this institution of medical history affect your ability to operate effectively as a medical practitioner for the rest of your career? You'll then submit that to me. We'll get the deadline out to you guys eventually, but you'll submit that to me, and there'll be a few rounds of back and forth, and ideally, by the time we're done, you'll have something that gets you that certificate for being a distinguished scholar of medical history, according to me. Sorry, that is the accrediting body for this certificate, right here. But also something you can put in your medical portfolio, and if nothing else, it will likely help you moving towards rotations and residencies, and it certainly will not hurt. So I'm going to take the Hippocratic nod right there, and I think the certification, if nothing else, will do no harm. Thanks so much.